Welcome. My name is Jeremy Eschliman. I am a DRPH student at the University of Nebraska Medical Center. This presentation is a project of the course Applied Epidemiology, College of Public Health 621, Epidemiology 821, Section 80, Fall 2025 term. This study explores the relationship between blood lead levels and hypertension among U.S. adults. Hypertension remains one of the most important contributors to cardiovascular disease in the United States. While lead exposure has declined dramatically over time, it does remain a persistent environmental toxicant with no known safe level. Today I'll present findings from a national analysis examining whether contemporary blood levels are associated with hypertension among U.S. adults. I'll start by briefly describing the public health burden of hypertension, because it remains one of the leading contributors to cardiovascular disease and preventable mortality in the U.S. Next, I'll review lead as a cardiovascular risk factor, focusing on what we know from prior epidemiological research and how that evidence has evolved as population lead exposure has declined. I'll then evaluate associations between blood lead and hypertension using nationally representative NHANES data from 2017 through March 2020. Finally, I'll discuss what these findings mean for environmental health practice, particularly around surveillance, prevention, and risk communication in low exposure settings. Overall, the goal is to understand whether lead remains an independent contributor to hypertension at contemporary exposure levels and what that means for public health practice. Hypertension is a major contributor to cardiovascular morbidity and mortality, acting as a national leading modifiable risk factor for heart disease and stroke. In fact, high blood pressure accounts for roughly half of major cardiovascular events, including stroke and coronary heart disease. Hypertension costs the U.S. approximately $131 billion annually in healthcare services, medications, and lost productivity. Although overall lead levels in the U.S. have declined substantially, exposure is not evenly distributed and disparities persist across populations. Lead is a persistent environmental toxicant that remains in housing, soil, water, and infrastructure long after primary sources have been reduced. Importantly, there is no known safe level of lead exposure, and health effects have been observed even at very low concentrations. Because of this, lead continues to be a public health concern, particularly in communities with older housing stock or legacy environmental contamination. This background raises an important question. As population exposure levels decline, does lead still contribute to cardiovascular risk at contemporary levels? Lead exposure has been consistently associated with elevated blood pressure. The mechanism for lead for increasing blood pressure is through effects on vascular function, oxidative stress, and kidney regulation, with the strongest evidence coming from the periods of higher historical exposure. Associations were strongest in studies conducted during periods of higher historical exposure. However, evidence linking lead exposure to hypertension at contemporary exposure levels remains limited. Despite strong evidence linking lead exposure to elevated blood pressure in the past, uncertainty remains at the low level observed in the United States today. Much of the existing literature reflects historical exposure conditions that no longer represent current population risk. As a result, it is unclear whether lead continues to act as an independent risk factor for hypertension at contemporary exposure levels. To address this gap, the objective of the study was to assess the association between blood lead and hypertension using recent nationally representative NHANES data from 2017 through March 2020. This objective guided the selection of the study population, exposure and outcome definitions, and analytic approach, which I'll describe next. To examine this question, we use data from the National Health and Nutrition Examination Survey, or NHANES. NHANES is a continuous national representative survey of the U.S. civilian non-institutionalized population that combines in-home interviews with standardized physical examinations and laboratory measurements. One of the major strengths of NHANES is the quality and consistency of its data, including objectively measured blood pressure and blood lead levels, rather than relying solely on self-report. We specifically use data collected prior to the COVID-19 pandemic to avoid potential disruptions in data collection and healthcare access that occurred during that pandemic period. I developed a direct cyclical graph, also known as a DAG. It's a conceptual model that helps summarize our hypothesis that blood lead may be associated with hypertension, while age, sex, race, ethnicity, and education may confound their relationship because they relate to both exposure patterns and baseline hypertension risk. What I'm trying to show is that blood lead exposure is related to hypertension. In this diagram, solid arrows represent the primary causal pathway of interest, which is the hypothesized effect of blood lead exposure on hypertension. These arrows indicate the relationships we're explicitly evaluating in the analysis. The dotted lines represent potential confounding relationships. These indicate variables that are related to both blood lead exposure and hypertension, but are not the direct exposure outcome relationship we're trying to estimate. For example, age, sex, education, and race or ethnicity may influence both the individual likelihood of lead exposure and their baseline risk of hypertension. If these factors are not accounted for, they can distort the observed association between lead and hypertension. By identifying these confounding pathways in the DAG, we clarify why these variables were included in the multivariable regression model to block backdoor pathways and better isolate the independent association between blood lead and hypertension. The primary outcome in this analysis was hypertension, defined using measured blood pressure values and or self-reported use of antihypertensive medication consistent with standard NHANES definitions. The exposure of interest was blood lead concentration measured in micrograms per deciliter from venous blood samples collected during the NHANES examination. Blood lead was selected as an objective biomarker of recent lead exposure. Several covariates were included based on prior literature and the hypothesized DAG that we just mentioned, and their known associations with both lead exposure and hypertension. These include age, sex, race, and ethnicity, and educational attainment. Age was included because blood pressure increases with age, that's a known factor, and older adults may have higher cumulative lead exposure. Sex was included due to known differences in hypertensive prevalence between males and females. Race and ethnicity were included to account for well-documented disparities in both hypertensive risk and environmental lead exposure. Education was included as a proxy for socioeconomic status, which is associated with both exposure risk and cardiovascular health. These variables were treated as potential confounders and included in the multivariable model to isolate the independent association between blood lead and hypertensive. We approached the analysis in several steps. Analysis accounted for NHANES complex survey design using sample weights, strata, and PSUs. First, we used descriptive statistics to summarize the study population. This included calculating percentages for categorical variables and averages for continuous measures such as age, blood lead levels, and blood pressure. Next, we concluded bivariate analysis to explore unadjusted relationships between blood lead levels and hypertension, as well as between key demographic factors and hypertension. Chi-square tests were used for categorical variables, and t-tests were used to compare average blood lead levels between groups. Finally, we used multivariable logistic regression to examine whether blood lead levels were independently associated with hypertension after accounting for other important factors such as age, sex, race, and ethnicity and education. Results from the regression models are presented as adjusted odds ratio with 95% confidence intervals, which describe both the strength of association and the precision of the estimate. I'll start by briefly describing the study population, then I'll move into crude and adjusted findings. The study population was middle-aged on average, with slightly more females than males, and a high prevalence of hypertension. The sample was racially and ethnically diverse, pretty similar to the U.S. population, allowing us to examine disparities in hypertensive risk. A key finding noted on this slide: the study population really does reflect a nationally representative sample and with low average blood levels and high prevalence of hypertension. This figure shows the crude, unadjusted prevalence of hypertension across quartiles of blood level concentration, with quartile 1 representing the lowest lead levels and quartile 4 the highest. As you can see, we observed a clear stepwise increase in hypertensive prevalence with increasing lead quartile in the unadjusted data. These results are descriptive and do not account for age, sex, race, ethnicity, or socioeconomic factors which may confound this association. This crude pattern motivated really the additional analysis into this, the multivariable analysis that follows this, where we adjust for key covariants to better isolate the association between lead exposure and hypertension. It is important to emphasize, as the last slide just showed, that crude or unadjusted associations do not imply causation. In the unadjusted analysis, we observed a higher prevalence and higher blood levels as the quartiles went on. However, this relationship does not account for the other factors, as we mentioned, the potential covariates, lead exposure, hypertension, as associated with that. So key characteristics such as age, sex, race, ethnicity, and educational attainment influence both an individual's likelihood of lead exposure and their baseline risk of hypertension. When these factors are not accounted for, the observed association may reflect confounding rather than true independent effect of lead. Now, after adjusting for these covariates in multivariable logistic regression, blood lead level was no longer statistically significantly associated with hypertension. This suggests that the crude association was largely explained by underlying demographic and social factors rather than a direct effect of lead at contemporary exposure level. On this slide, I'd like to present the forest plot, which shows adjusted odds ratio from the multivariable logistic regression model. Significance is determined by whether the confidence interval crosses the null value of 1. And as you can see by the dotted line vertically is what we're talking about there, but not simply by whether the odds ratio is above or below 1. For reference, the p-value we use, which is the significance for blood level, was 0.21, which means not significantly associated, while age, sex, race, and education were all statistically significant, noted by the p-value of less than 0.001. After adjustment for age, sex, race, and ethnicity and education, blood level was not independently associated with hypertension, as the confidence interval crosses the null. In contrast, age, sex, race, and educational remain strong predictors of hypertension, indicating that much of the crude association observed earlier by lead was explained by confounding. These findings suggest that at contemporary exposure levels, lead does not independently explain hypertensive risk in the population. Now, these findings are best interpreted in the context of prior literature. However, after adjusting for age, race, sex, ethnicity, and educational attainment, blood level was not independently associated with hypertension, as we mentioned. This finding aligns with more recent studies indicating that at current environmental exposure levels, generally much lower than what historical research has indicated, the effect of lead on blood pressure may be attenuated or obscured by dominant traditional cardiovascular risk factors, such as age or other social demographic factors. Several strengths enhance the rigor of the study, including the use of nationally representative NHANES data, standardized blood pressure measurements, and high-quality biomarker assessment of blood lead. Nonetheless, important limitations warrant consideration. The cross-sectional design precludes inference about temporality or causality, which limits our ability to infer between lead exposure and hypertension. Blood lead reflects relatively recent exposure and may not capture cumulative lifetime burden, which is more relevant for chronic disease development, as blood lead was measured as a single point in time and primarily reflects recent exposure rather than cumulative lifetime burden. Because lead has a relatively short half-life in blood, this measure may not fully capture historical exposures that are more relevant for chronic cardiovascular outcomes. Residual confounding may also remain despite adjustment for key demographic factors. As a result, some degree of non-differential exposure misclassification is likely. This type of measurement error would be expected to bias effect estimates towards the null, which may help explain the attenuation of associations after adjustment. Taken together, these limitations suggest that a null or attenuated finding at low exposure levels should be interpreted cautiously, particularly in the context of cumulative and historical lead exposure. Health risks are not shared equally. That's the biggest take home from any public health perspective. Even with lower lead levels today, some communities still face higher health risk due to long-standing environmental and social inequities. Lead prevention still matters. Average lead levels are lower, but with continued monitoring, it's still needed to identify people and places with ongoing or hidden exposure. Surveillance protects progress. Ongoing tracking helps ensure past public health gains are maintained and emerging risks are detected early. Low exposure does not mean no risk. There is no known safe level of lead, especially for vulnerable populations, pregnant women, younger kids in particular. Clear communication is essential. Public health messages should be honest, practical, and focused on prevention without causing unnecessary alarm. Lower exposure levels reflect public health success, but continued surveillance, prevention, and clear communication remain essential, especially for communities at highest risk. One implication of this finding is how confounding can inflate associations in unadjusted analyses. Blood lead levels were associated with hypertension in crude analysis, but this relationship was attenuated after adjustment for demographic and socioeconomic factors. It really just shows the importance of the work we're doing in epidemiology. These findings are consistent with emerging evidence suggesting that at contemporary exposure levels, lead may play a smaller role relative to established risk factors. Continued surveillance of environmental exposure remains important, particularly in populations experiencing disproportionate cardiovascular risk. This analysis highlights the value of nationally representative data such as NHANES for examining environmental exposures and chronic disease risk at the population level. While blood lead exposure remains an important public health concern, our findings suggest that at contemporary exposure levels, demographic and socioeconomic factors continue to be the dominant drivers of hypertensive risk. I'd like to thank the National Health and Nutrition Examination Survey Program for making these data publicly available, and for the University of Nebraska Medical Center for the opportunity to complete this work as part of applied epidemiology. Thank you for your time and attention, and I'm happy to take any additional questions after completion of this presentation. These are the key references that inform the background and interpretation of this analysis. I'm happy to provide additional citations if there is any questions. Thank you very much. Have a great day.